So CARTITUDE-4 is the first phase 3 study that is comparing Cilta-cel versus standard of care in patients after the first relapse. So the patients included in the study were patients who had 1 to 3 prior lines of therapy and were lenalidomide-refractory. And the patients were randomized into either Cilta-cel arm or against the standard of care arm. And the standard of care arm chosen were 2 effective regimens. One is called daratumumab pomalidomide dexamethasone, or DPD, and the other one is pomalidomide bortezomib dexamethasone, called PVD. And these 2 regimens, when the study was designed, are the most widely used and probably the most effective regimens in 2019 when the study was designed. Now, so the patients, once they're randomized into standard of care arm, they continue to either DPD or PVD, that is based on physician's choice till progression. The patients on the Cilta-cel arm undergoes apheresis, lymphodepletion, bridging therapy, lymphodepletion, and then Cilta-cel infusion. And after that, they will just be followed up without any treatment. Now, it is important to note that in the study, the bridging therapy is the same as the standard of care arm, either PVD or DPD. Okay, so these 2 regimens are, so the patients are getting this similar regimen or the same regimen for the first 8 weeks when the patients in the Cilta-cel arm are waiting for the CAR-T manufacturing. Now, the choice of either DPD or PVD, again, is the physician decides prior to screening, and with the understanding that the optimal regimen is chosen based on prior exposure and refractoriness. The primary endpoint of the study is progression-free survival, and there are multiple secondary endpoints that we assessed, like response rates, MRD negativity rates, overall survival, the Cilta-cel pharmacokinetics, and the patient-reported outcomes. What we saw, so I will just give you a brief patient flow diagram and the patient demographics. So there were about 419 patients, 208 were randomized to Cilta-cel and 211 to standard of care. In the Cilta-cel arm, 176 patients were able to receive Cilta-cel as study treatment. 32 patients had disease progression or died and are counted as PFS events. Out of that, 20 patients were able to give Cilta-cel as subsequent line of therapy, and the data will report it in the due time. The baseline characteristics of those 2 arms are well balanced. There is nothing unusual in each arm in terms of the high-risk cytogenetics, the soft tissue plasmacytomas, and all other high-risk markers that are well balanced among the 2 groups. And then in terms of efficacy, we saw the Cilta-cel significantly met the study met the primary endpoint with Cilta-cel reducing the risk of disease progression or death by 74% versus standard of care with a hazard ratio of 0.26. This is the best hazard ratio that has ever been reported in this patient population in a randomized setting. The median PFS was not reached in the Cilta-cel arm and was 11.8 months in the standard of care arm. The 12-month PFS rate was 76% in the Cilta-cel arm and was 49% in the standard of care arm. Now, when we look at the subgroup analysis, we saw the Cilta-cel consistently prolonged PFS benefit in all subgroups, including the high-risk subgroups, which are the difficult to treat patient population. Cilta-cel also led to higher response rates, including the deeper responses and MRD negativity rates compared to standard of care. Now, when you look at just the patients who were treated with Cilta-cel as study treatment, the 176 patients, the response rate was 99%, with 86% achieving complete response or better, and 72% were MRD negative. In terms of safety, the data are consistent with what we saw in Cilta-cel product per se. And if you look at the 176 patients who received Cilta-cel as study treatment, the rates of CRS, the rates and severity of CRS were much lower than the Cilta-cel when used in later lines in CARTITUDE-1 patient population. The rates of delayed neurotoxicities, including MNT, was also lower in rates and severity, suggesting the Cilta-cel may be better tolerated when used in early lines of treatment.